Thank you, John. I'd like to say thank you to Jim Esch and J.P. Warner and Matt Proventure for providing me the opportunity to speak today. So we'll get this session started with the arthroscopic basics, and as John had mentioned, this is setting yourself for arthroscopic success, and that's the plan and setup. And we'll try to make this as relevant as possible in terms of everyone's practice in the everyday world. So we all know that complex shoulder arthroscopy is a series of little successful steps all along the way. It's not one big thing or two big things. It's a whole bunch of little things that make it all happen. And so what really matters, I guess, in the end is the outcomes for the patient. And so you have to hit all of these different things along the way, that being the history, physical exam, diagnostic imaging, getting the correct diagnosis, having a plan, that being plan A, B, and possibly even C, discussing all this with the patient with possibilities, and then documenting and communicating. History is always very important. We're always worried about sick patients and what that may mean, but probably the medications is where the opportunity is most problematic potentially in terms of anticoagulants. It only takes one drop of blood to basically ruin your whole entire field of view, and so you have to ask those questions not only about the conventional blood thinners, that being things like warfarin, aspirin, NSAIDs, and Plavix, but also the non-conventional things that people take all the time, like turmeric, garlic, ginger, and even bromelain, which is in pineapples. Certainly the preoperative plan is important with a full set of radiographs and an MRI, but as we get into instability surgery more and more, we're learning that 3D reconstructions on CT with humeral head subtraction can be very useful. And these are very important to review before and have available during surgery. It's surprising how many times this will change your plan. In terms of the assessment and plan, certainly you want to establish this in the clinic with the patient and talk about the rehab at the end and confirm this on the day of surgery, and then basically go ahead and execute that plan and have everything available for you. I like to talk to the patient obviously at the day of surgery, mark the site, check for infections, and even check for, do a cursory exam, that being check for stiffness of the shoulder, inquire about allergies and review systems, and then actually confirm that the things that we're going to operate on need to be addressed on the day of surgery. I do everything in the lateral decubitus position. There are gobs of arguments about which way you should go with this. For me, the lateral decubitus is quick, reproducible, safe. Certainly this is, you put the patient in the on the bean bag with an axillary roll, lean them back 30 degrees, and you can adjust how much abduction you need. You need to be careful to pad the forearm for superficial radial nerve injury and use only 10 pounds of balance suspension traction. And you can see here you've got nice access to the entire shoulder, and not only does the lateral decubitus provide a safe environment to operate on the shoulder, but also gives you a 360-degree angle on things. And there is some literature to suggest that, particularly with instability surgery, you might actually be able to reduce your recurrence rate. And in this particular article, they found that with lateral decubitus, there was 8.5% recurrence rate versus 14.6% with the beach chair position. You need to know how to troubleshoot any positioner. In this particular case, the weight was touching the rail on the side of the bed, and with just a little bit of pull on the arm, my view in the subacromial space went from this to this, where I can see the rotator cuff tear in the lower right-hand corner. So you have to be mindful about what you're looking at and how to fix this correctly and quickly. A good examiner anesthesia certainly is important, and doing this every time. And with my setup, I typically use a Mayo stand where I have all of the tubes and wires and things that need to be connected to anything come right off the back of the Mayo stand on the opposite side of the operative field. And on the opposite side, as you look across, I typically try to put the monitor superiorly, and then certainly the water towards the foot of the bed so that the circulators can get to this readily without having to dig into the corner of the room. Portal placement, we all know about this. Your standard posterior portal along with your mid-glenoid portal, your anterior superior portal. These are your basic workhorse portals, of course. But I think it's important to try to learn in the lab about the 7 o'clock portal and even the percutaneous subscap portal as we get more aggressive with doing things arthroscopically and get more comfortable with addressing things in these tougher to get locations down low. And draw out the markings every time, because certainly these are situations where the morphology is different in every patient, and you get all different sizes and shapes with this. You need to know your equipment, certainly the cameras, the scopes, the data management systems, and so on. And invariably, there's always something that goes wrong when the person who knows how to fix this leaves the room and you're left guiding someone who has no idea. So I think the more you know, the better. Anesthesia is crucial in this whole setup. I can't emphasize enough having a good anesthesiologist who's willing to work with you, who understands shoulder, is interested in it, and will basically do interscalene blocks readily on anyone that walks through the door, and is comfortable with the 1% complication rate, which is typically numbness that resolves within 4 to 6 weeks. Oftentimes you'll get into a discussion with an anesthesiologist who's uncomfortable with things, that being blood pressure discussions. And you can see here I'm pointing at the monitor and the anesthesiologist is pointing at the patient. And we're having a vigorous discussion about cerebral oxygenation saturation, that being what's safe and what isn't. So in the beach chair position, it's typically greater than or equal to 20, whereas in the lateral decubitus, it's 0, because the head and the heart are at the same level. And so you have to speak their language and be able to talk to them in a way they can understand so that the two of you are on the same page. We all know that a blood pressure of 157/72 with a mean arterial of 104 is not ideal, and a mean arterial of 73, as you see on the right-hand corner here, is far better. And so you want to basically try to keep the mean arterial pressure between 70 and 90 millimeters. And another easy way to look at this is a systolic blood pressure of 100 if the patient can tolerate that. There are bleeding hotspots in the shoulder. You can see here on Netter's classic drawing, there's an anastomosis around the acromion, and right in the front of the shoulder as you look through the lateral portal, I'm preemptively cooking this with an RF device, and this is the area where I'm cooking this with the yellow circle in the front. And here, there's oftentimes a bleeder in the front of the acromion, as you see on this axillary view, and one laterally here. So you can, and if it starts to bleed, you can actually just put a finger on it, put your shaver on there, hold pressure for just a brief moment. Oftentimes you can get it to stop just with doing that. Bleeding, as I keep talking about bleeding, because these are the things that really slow you down with efficiency, and radiofrequency ablation is great, particularly with more complicated cases and with more complicated dissection. So it's good to find one that you can use and also afford. Cannulas are certainly a great thing to have. You can work through the cannulas. It provides distension and a working place, as well as limiting the amount of extravasation that can occur in the shoulder in terms of as the case gets longer and longer. And this is an article that I've talked about a lot because I think there's a lot of truth in this. Steve Burkhart talks about the Bernoulli effect, and that effect is when you're standing in the shower and the water rushes by and the shower curtain sticks to your leg. Basically, as if you've got a leak and you don't plug that leak with a cannula of some type, the high velocity of flow will actually draw blood into your field of view and then churn up and create a very murky environment to operate. And so if you plug that hole with a cannula, you can do yourself quite a bit of good. And I like to use the reusable systems. All the companies have them. But basically, you can jump from the anterior, the lateral, and the posterior portal, all with a bridge system, and it's very inexpensive. Inflow is also very important for improving your view, and certainly you can use a high flow sheath, or what I like to do is a dedicated inflow. And if you use a dedicated inflow, consider using one where not only the edge of the cannula is at a 45-degree angle, but there's also holes on either side so that you never get occluded off. The water always can find a way out. And that leads us to the water or the fluid. It's typically it's an isotonic solution, which is safe, and it's typically saline or lactated ringers. I do add epinephrine to the first 4 bags, and you can go up as high as 1 milligram per liter in terms of the bag concentration. But if you continue to use this throughout the case, you can get into a rebound hypertension problem. So you really want to limit this to the beginning of the case. And that's usually the time when the anesthesiologist is getting the pressure down. So by the time you've gone through those bags, the patient's fully anesthetized and things have settled down, and you can do your procedure. In terms of using a pump versus gravity, I still use gravity, which requires a chamber with tubing. It's simple, it's inexpensive. You need to have 1 bag open at a time, and you need to have a fancy IV pole that allows you to have a weight assist and raise the bag up as high as you need to go. Just remember, whether you're using a bag, an IV pole, or a pump, if the patient's sitting up real high, that pressure gradient is always still there, so things have to work hard to work uphill. If you have have to troubleshoot a red out, basically there's things that have to go through your mind to try to correct that as quickly as possible. That being, are the bags full? Is the pressure completely off the charts? Did the cannula fall out, or is there a kink in the line? Typically the circulating nurses get very busy towards the end, and they're trying to do their documenting, and they forget to spike the bags all the way. So these are all the things that you should check and go through in a pretty rapid fashion to correct your view. There are little devices that are fluid alerts that can be utilized where it senses when the bag is running out, and that will prompt the circulator to go and get more fluid and hang the bags. I find that the nurses hate these, and they hide them in the closets, so they don't really get used in my institution for whatever reason. So in terms of plan and success, I do spend some time the day before and try to manage the case order. And that being, I always try to start out with a healthy patient and bring in the sicker patients to follow. That will give the nurses some time to do things like IV Vanco, which can take an hour to run in, latex allergies, anything, an A-line maybe that they need to do, the mandatory anesthesia fart around time, the Mayfat time, whatever that may be. The other thing is I like to store the implants in the room if possible, have extra fluids available, and also the IV antibiotics in the room so that when you go to do your timeout, there are no delays and people running all over trying to find things to get going. In terms of parting thoughts here, I think turnover is a killer. It really can slow down a day, and if you're using one room or two rooms, try to put all your right shoulders on one side and then lefts on the other, or vice versa, so that the people cleaning the rooms don't have to keep moving things back and forth and back and forth. I typically hang around the OR quite a bit. I try to encourage people to do it correctly, but also do it efficiently. Sometimes if there's a very vigorous discussion about recipes.com or whatever, I'll join in and I'll start opening the room with them, and that tends to help keep the turnover at a good pace. I'll answer any questions that are needed. And the other big thing is I try to really preach avoiding clutter in the room, because that can create sterility problems, people running into things, tearing down things, having to re-prep and drape things, which is very problematic on so many levels. And so I think orderly and tidy working spaces are a good thing. So in conclusion here, I think it's important not to forget about the basics, that being the history, the physical, the diagnosis. Certainly. Interscaling blocks are key to being able to get all these things done. Have all the equipment available that you need. Try to eliminate any unnecessary steps, and certainly try to meet your patient's expectations, and that means discussing with them preoperatively what may happen postoperatively and how that will all go. Thank you.